So actually I need more hands here. Right, clinical skills, these are all the things I will cover. So instruments, I think very quickly, I think all of you know, I just go one round. Kidney dish, gallipot, gauze, suture scissors, needle holder, tissue forceps, arteries, cheek retractor, langham bag. This is what I mentioned. It should be about this length. Then this is a blade holder, your standard diagnostic tools, probe, mirror, tweezer. This is granular with irrigation, needle. This is periosteal elevator, Mitchell trimmer. This is Buser, very nice instrument, Buser. Bone file, straight Warwick, curve Warwick James, couplers 1, 2, 3, luxator, Cryers, tower clip, Alice forceps. So I don't use Cryers anymore. In fact, my inventory doesn't have Cryers because previously I've seen Dr. Dwayne Moyes using Cryers and the angle of the mandible fracture. Because Cryers have that handle that can exert so much force and you can really force your way through. But if you use curve Warwick James to replace that, curve Warwick James have such a slender handle, so tangan you akan sakit dulu before you exceed that force. So usually I don't use curve Warwick James Cryers anymore. Alright? Oh, sorry, I have a zoom in picture actually. So luxator and couplant, the difference is luxator is only used in apical force to cut the PDLs actually. They are not meant for you to elevate. And most of the time, if you have luxator in the clinic, you will like it so much because usually that is the instrument that can go in when your teeth fractured. But you are, no matter how tempted you want to elevate with your luxator, please don't. Luxator is 300 plus, okay? You elevate with the luxator will be bent. And then that luxator gone already, you cannot use it for other case. Make that space, just apical force, to elevate, change to couplant 1 for elevate. Luxators are not for you to elevate. Boleh I know, because I see so many bent luxators in my clinic. Okay, then you have, this one I go through already. Right, so I think this one I don't need to tell you. Handling instruments, of course you don't point the sharp end to your assistant. And then needle holder, there are too many ways to hold it. In fact, sometimes I don't even hold it like this also. Sometimes I don't use that 2 loops because what you want is just movement of the wrist. So when you do suturing later, especially in the phantom head, I will tell you. And if I see any one of you suture it slightly wrongly, I will tell you how to overcome it. This one not important. Right, tools. So if you are still in KP, they will just say use the dental chair, use the straight handpiece in the dental chair. So the thing is, dental chair runs on compressed air. So sometimes as it rotates, you will have some air coming out. So at all times when you use the straight handpiece, if it's not a designated surgical motor, you cannot turn off the air because that's the air that runs the handpiece. You might have emphysema. Just bear in mind about that. So that's not what I recommend, but that's also what I did when I was in KP because we don't have. So next, you have rear exhaust high-speed handpiece like this. 145 degree. They are high-speed burr that they tell you that the air comes behind. So it's a retro exhaust compression air, which means that you have reduced the risk. Okay, good for very simple cases, but the limitation is that the burr that you put is that length. You cannot lengthen the burr just like your straight handpiece. So once you are dealing with roots, they become very useless because they can't reach the depth that you want. So I've done that also. I've used that also. I don't quite like it. In fact, I slightly trim the adjacent teeth a little bit at the enamel. I have to do composite for the patient because I'm not used to this. Because everyone says, hey, try this. So I try lah. So it's not my tools. Then you can do electric motor like this. Okay. So this you can see that actually is used by denture technicians, but they run from motor. You plug in, dia jalan. Compressed air, no compressed air. At least it is still safer, but you need to change this end to the metal autoclavable part lah, not the thick one like the technician use. Then you can put in your straight burrs and then you can use it for surgical reasons. As long as they can reach 40,000 RPM, I think they're quite good. And you have to externally give the irrigation. Then of course the best, it will be surgical micromotor, the one you use for implant, the one that comes with irrigation at the same time, can be contra angle handpiece, can be straight handpiece. Those are the best, but not everyone has that. Right, so giving a block, of course you give a nerve block. Tongue scratch means It's just my personal thing lah. So when I give block, sometimes patient tongue will come, isn't it? The moment you want to give, the tongue comes. And when you tell a patient, lidah tu ke tepi sikit, even more the tongue will come. They will not move away. So I have learned the hard way that don't tell the patient to move their tongue away. So it's not going to happen. So what I do is, if this is the tongue, and I have my LA, I have my needle, I will just, and the tongue will move away. Don't say anything about the tongue. Touch the tongue only, and they will move away. They will move away. Most of the time lah. Unless the patient is very, very anxious and very, very stiff, they refuse to move their tongue away from the back of the throat because they're worried of ingestion or what, I don't know. Then you have a hard time. Boleh na? So what I like to do is you can try. Next time you want to give a block, the tongue comes up. You just touch a bit, behind not cucuk the tongue, and then you will move away, and then you quickly give the block, okay? So block, I don't have to tell you. And this one you want to charge at the same time. Charge this together. Okay. So, and then you give the long buccal nerve block. Once you give the block, I don't have to tell you how to give block. You all know how to give a block. Usually I come from the contralateral premolar region and do it. Then you give the long buccal, but when you give the long buccal, I don't need to feel the bone. Because when you give the block, you need to feel the bone. So to know that you don't exit beyond. So then you retrieve the needle, then you inject. But for a long buccal, you don't need. Just go into the sulcus and inject. In fact, you touch the bone means pain already. So only into the sulcus and deliver your solution. Right. And then intraligamental, I always do that also now. So once I give the block, long buccal, inferior alveolar nerve and long buccal, I give them some time, 3 minutes like that, I wait. Then before I start, I'll say, now you feel a little bit numb, I will give around the teeth. But you might taste a little bit bitter. I will tell them, I'll give under the operculum, in the PDLs, between the 8 and the 7, because the moment you raise the flap, you can't give anymore. And then the moment you raise the flap, you do gutter, all that, then the pain comes, what are you going to do? You can't give intraligamental anymore because now you want to inject into that area, they will leak. And sometimes when you give intraligamental, they are not a true intraligamental. So what do I mean by they are not true? It means that the solution maybe sits subperiosteally. You think you give intraligamental, but then you see the gum blanch a bit. Maybe they sit underneath your periosteal. Faham tak? Understand? Yes? No? Yes. It's okay if it sits subperiosteal because it just makes your elevation easier later. Because the solution done the job already. Understand? So I always give that, then only I will test with my probe 9, and when I test, I really test hard, the head must shake one. Not scratch like that, no. I really go into the crevice and make sure they understand what is pressure and what is pain. So in the videos also you will see that. Then only I start my surgery. And then people always ask, still pain? Still pain when I do the MOS, how? So if you already done the gutter, okay, and during tooth sectioning you still have pain, you are left only 2 options. One is you tell the patient, I will give you, but I really need to go a little bit deeper, then I will deliver, means intrapulpal. The moment you can see that point of bleeding during a section, you stop and then you give the LA, but warn the patient he's going to be sharp. Okay? But another option is actually intraosseous. Means that I give into the marrow. You see, you will do gutter, right? And then they will have point of bleeding, right? Actually, it bleeds from the marrow. It doesn't bleed from the cortical bone. Bone has cortical bone, which is compact bone, and your cancellous bone, which is marrow. Once you do your gutter, if it's deep enough, you will have bleeding, right? That is bleeding from your marrow. So I actually will give a little bit, but I don't point towards the, because as you go deeper, you worried that my needle will directly hit the nerve bundle. So maybe I will point it to the buccal side, laterally. But I give inside the bone. This one I only deliver once or twice in a year. Means that I do not routinely do that. So I call it intraosseous lah. But that one works magnificently. Because after that, again, they will feel something similar like intrapulpal, and then they will be so numb. And you usually can do what you want. So there are good things and bad things. Some people think that if you make it so numb, then you won't know if you're too near to the nerve. But for me, I really don't want them to have pain during the surgery. And then it's quite common to feel a little bit when you elevate the teeth up also. when you elevate the teeth out, because you actually tear the nerve from the main bundle going to the apex of the root, you tear that apart. So I think undoubtedly you have some discomfort. Alright? So I always give block, long buccal, I always give intraligamental, but I do not always give intraosseous. I do not always give, okay? But that are usually a very, very last resort. Right. Right, so, and then I always give step dose lah. I always give step dose before I start. So I take consent already. Then it's either you give LA while waiting that 3 minutes they swallow the medication, or they take first before I give a jab. Why? Because when the pain subsides, the painkiller that I serve is already in the absorption. So I always give step. I think that's very good for patients' comfort and for the transition of their pain control. Alright? Okay, so then some people say use Articaine, don't use whatever you have. Usually for Articaine, they are quite good if you compare to lidocaine lah. A lot of research show that it has superior anesthetic effect compared to lidocaine, but we don't really use lidocaine anymore. I think most of us are using this, which is mepivacaine lah. But for mepivacaine per se, as much as I want to find the evidence, they find that they are quite equally good. It's just that you need less amount. Means that one Articaine maybe is somehow equivalent to 2 or 3 cartridges, which makes sense because Articaine are more expensive. When you buy also, they cost around 2 to 3 times the mepivacaine. So they have faster onset lah. Basically, Articaine has faster onset and they are more potent. Alright. And then if using Articaine to give a block causes any increased risk of not, this is a systematic review. Quite a very big sample size. They say that it do not increase the risk lah, compared to any other local anesthesia, which I think it makes sense because when you give a block, it's a blind procedure. I will never know where my needle ends up. If it ends up that coincidentally in through the vessels or scratch the nerve bundle, then of course you will have some permanent injuries. But if you can cause that, I think you can buy Magnum or Toto already. Means you're that lucky. It's so rare, you know. Alright? Okay, so flap design. This, watch out for caries teeth, treat it as retained root, I already told you. You have triangular and envelope. I'm just going to touch these two. Why does it bleed? I will tell you later. And is small flap better than big flap? It depends on you and your team. Because when you raise a flap, everybody has a place. They know where their suction should be, they know where their things should be. If the flap is too small, sometimes the assistant don't know where to put, and the water will just flood, and then you can't see. And when you can't see, you will suck, then the whole thing becomes slower. Your surgery becomes slower. So you have envelope flap or triangular flap. Envelope flap means no relieving. Triangular flap means what I said just now with a relieving. So both are quite good, but I would say try to master triangular flap before you want to go to envelope flap. Envelope flap is easier to close because no relieving, so you're not worried about vascularity of your flap. But I have not seen any flap necrosis because of MOS before, because you do triangular flap. As long as your relieving has a wide base, vascularity will come. You won't die, your flap won't die. And it has limited visualization because as you retract envelope flap, you takut dia akan koyak kat depan because you never do the relieving. So for beginners, when you want to see things and you're not sure the anatomy, maybe you do a triangular flap. It has very good visualization, and another advantage is that you can advance it when you close it. Envelope flap, you most likely won't be able to advance it. You will leave a small gap behind the 7, so it can still go in a little bit. They say that if you do envelope flap, there's less risk of periodontal pockets or recession, things like that. I think that despite those 2 flaps, because of the gutter that you do, of course, the bone level has gone down. And whatever flap that you raise, it will eventually rest on where your remaining bone level is. So a lot of teacher also doesn't say which one is superior to another. They don't say that this one will cause pocket and this one doesn't cause pocket. They also cannot conclude. So for today's purposes, I will just focus on triangular flap, and you all will do triangular flap for today, yeah? Right. So when you want to do, usually you give LA, all that ready already. What you do is you will palpate, and then you want to cut. So my advice is, if this is the blade, Okay? Maybe you're holding a cheek retractor, isn't it? Cheek retractor. So when you want to cut, hold the blade and use your finger to palpate. Your eye knows where is external oblique ridge. Your eyes don't look left and right anymore. You already know which point, then you cut. That's one way. Second way is, you want to cut but you're not good at this manipulation because you worried the blade cut someone else. Maybe have your assistant to hold the cheek retractor, your eyes here, your left hand palpate. Okay, these are all bone. Then you cut, but don't cut your finger lah. Understand? What I don't like is that you leave the blade on the table. You hold mirror lah, cheek retractor lah. You palpate, happy already. Okay, I know this is my incision. You look somewhere else. You go and take your blade, then you come back, you straight away want to cut. That I don't like because you lose that spot. Why? Because your incision is to stay on bone. And all this is not on bone. Your mandible most likely curve outwards. What's at the medial side has no bone. And if you don't stay on the bone, you cut the pterygoid muscle, oh yo, you haven't started and it bleed. And you cannot even do your MOS. So make sure your incision stays on bone. And the direction of a blade, because we will always stand at the buccal side, the lateral side. So you tend to point the tip of your instrument lingually. So make a conscious effort to angulate your blade laterally. Understand? The line is like this, but if you hold the blade like that, you still end up lingual. You have to hold the blade so that it is directed laterally. This is very important, right? And then, where does it end? See this line? This is attached gingiva. What's remain is keratinized gum and non-keratinized gum. Attached and free gingiva. This line, you can see that line? That is the mucogingival junction. Correct? Correct? Perio pula. Nah, hari ni main khusus perio. So you must make sure you go 1 to 2 mm beyond this junction. Don't stop before that junction. You stop before that junction, it's an attached gum, you will never be able to mobilize it and you're like, why my flap so tight? I cannot see anything. You know, must go, no need too much, just 1 or 2 millimeter beyond that junction. Understand? Okay. So this is what I told you. Don't point to that side. Point to this side. Understand? Because your mandible will curve. It will curve laterally. Alright? Boleh? If you feel that your blade has gone in so much, but you still cannot feel the bone, do not just go like that. Most likely you are not on the bone because you just felt with your finger. You knew already how much the depth. You felt the bounciness and the thickness of the tissue there already. Isn't it? So suddenly you put blade, why I cannot feel the bone one? Sure, your blade angulation is wrong. Understand? Very good. So, because some of you are expert, I know some of you done a lot of MOS already. I just gotta draw something. This is the let's say this is the 8 and then this is the 7 okay, so this is my gum, okay, and you have a fold, and then you have a mucogingival junction. Betul tak? You have your papillas, you have a 6, this is your 8, partially erupted. Now this is for between advanced and beginner already. You will make your incision. I already told you, number 1, do triangular flap. So we are cutting this. Number 2, please do not split your interdental papilla into 2. Nobody does that. Include the whole papilla into your relieving incision. So if this is the teeth, this is the teeth. Usually you go by the principle of 1/3 lah. Okay? You don't make the relieving at the middle because that is the most thinnest part and most difficult part for you to suture. You will cause a slit formation or recession. So you never do a relieving at the center. No matter you're doing implant lah, episectomy lah, retained root lah, you never stop at the center. So I would advise you to include the whole papilla and go down. 1 to 2 mm beyond mucogingival junction. Include the papilla because I've seen them separating the papilla into two. Why make yourself so tortured? Because later you have to suture it back. Now this part where you palpate, there's so many bone. Do you do it here or do you do it here? It means that you palpated already. All these are bone. I can put here, I can put here, I can put here. Betul tak? All of those lines are on the bone. When you're a beginner, you just go as laterally as you can. Janji is on the bone. When you are starting to refine your skills, you will go as lingually as permittable. Why? Because by the time you raise the flap, you won't leave a thick skirt there and you cannot do your work. Understand? Sekali lagi. So if you have line 1, you have line 2. If I do line 2, I raise my flap, isn't it? You will leave a lot of tissue here, and when you want to do the gutter, you find that you have this piece of flesh there, and it blocks your instrumentation. And then you ask your assistant, hang, tolak sikit tissue kat situ, maybe with another periosteo or something, then they will put in here to seal up, then you can do your distal gutter. But when you are already advanced, you will go as much as the bone allow. Because why? If I raise number 1, I don't raise number 2, then I have even less tissue at the lingual aspect. Sometimes I don't need my assistant to do that anymore because I can see straight. That's the end. Understand? Yes? Yes, clear? So when you raise a flap, always you put in your instrument and try to inspect whether you still have a lot of bone there or not. Boleh lah? So we go on back here to the next. So, okay, of course, if you have a recurrent case, you have a lot of scarring. If you have a lot of scarring, it's tend to be harder for you to raise the flap. Alright, so at what point do you start to elevate? So if I divide into 3 zones, the first thing I would raise will be the blue color line. That is the easiest part. You can start from this area, the 1 to 2 mm area, because that is loose gingiva, easiest. Punya instrument, tarik a bit, can see bone already. Then you move yourself upwards. But if you start from here and you want to move beyond the mucogingival junction where the gum is more stiffer and you use too much force, you will tear the flap. You will tear the flap. Dia akan koyak. So, slowly. Be careful, okay? All this in between, you dah longgarkan already. Then you start from here and you move upwards. Usually it's like that lah, for the blue line. Once you reach the blue line, you come to the black line. And the problem is always between the black line and the green line. That is where it is the tightest. You know why? Because your cut sometimes is not complete because it's blocked by the egg. This egg is so low and so deep, of course you can cut lah. But if your egg is slightly mesial and higher, sometimes it's difficult to go beyond that. Then you cannot raise the flap. So what do? Most people, they cannot raise that flap. They raise halfway already. Again, they will put their periosteo elevator down. They hold the cheek retractor. They take their blade and they complete that cut again. I don't advise you to do that. You raise the flap at the black color line between the green color. You got stuck. You are holding your periosteo elevator in your dominant hand. Your cheek retractor, ask your assistant to hold your periosteo elevator with your dominant hand. Pass to your non-dominant hand. Keep this area tense. Now take the blade and cut. Then your cut is on a tense mucosa. Then your cut will be effective. Because the problem is that you raise, you let go, you hold the cheek retractor because you insist to hold the cheek retractor, and you cut on the flabby tissue. It's not going to cut also. Betul tak? Betul tak? Right. Small things, you know, I tell you to that detail, you know. So, keep this, ask someone else hold the cheek retractor. You hold the peristyle, now the peristyle goes to my left hand. Now I use the blade and I cut, keeping that area tense. Understand? So this is the concept I call same person, right hand, left hand coordination. Can you hold the peristyle and ask your assistant to hold? Cannot. Maybe it slips. And you know how much to tense it. Maybe you tense it, you cut, jadi longgar dah. You can pull a little bit more and cut. It has to be the same person. Understand? Very good. Right. So this is the part where after flat elevation. Alright. So now bone gutter. Any questions? I tell you everything and all the common mistakes already for flat elevation. Alright? Any questions? Can I continue? Don't worry. You can always ask me. So now you start to do the bone guttering. And there's so many things inside, you know. You have a Langham bag. You use your ring finger because you don't want the burr to lie against the cheek. You want to protect and prevent. Then you have your handpiece. Then you have your suction. Sometimes you have a tongue depressor. Sometimes you even have an irrigation. At least 5 things going inside the mouth. So you're running very tight. So I like that the flat is where my assistant knows already. When I do gutter, they stay here or they stay there. They are always on the bone, not on the soft tissue because they can't suck when they are on the soft tissue. Then you get a lot of water. And then keep your handpiece if you can. Lean on the teeth rather than coming from the side. Coming from the side means you have a gutter that is wide and shallow. Keep on the teeth and make sure it is as close to the teeth as well. You get narrow and deep. Sometimes you are holding your handpiece as if you're writing calligraphy. And the handpiece feels heavy. And that's why you don't always rest the handpiece on the most comfortable space. Because when you do that, sure you're coming from the side. You need to hold like that with the ring finger on the cheek. Then you can do the gutter that you like. Understand? Right. So, okay. So then you do from mesial gutter, mesial buccal until all the way to distal. And if this incision is in line number 2, sometimes you get a lot of tissue there, you might want to ask your assistant to elevate it. Then you can continue. If they don't protect and you just go, sometimes you worry about injuring the inguinal nerve. Right? Okay, next. Guttering is very important because if you don't give space and you do your sectioning and then you part, you will have not a good split because you don't have space for the teeth to expand. So you need that space. So how much bone guttering? I would say expose the widest bulbosity of the teeth. If the teeth is very buried and the widest bulbosity of the teeth is not being exposed, no point. You still have undercut one. Your teeth is not going to come out. So there's no fixed figure. There's no fixed figure. Some will say, do until you see bleeding. Some will say, do until your whole burr buried. The round burr buried. There's no fixed amount because every infection case is different. Until the bulbosity of the crown is exposed, you're good. Understand? Right. Now, I want to introduce something because now we talk about tooth sectioning and everybody wants to know, oh, yo, doctor, I want to do a perfect section, perfect split all the time. I don't have. I'm very sorry, I will tell you, I don't teach you to have a perfect section every time because I also don't do perfect section every time. I teach you what happens when your section is not good. Okay, so you solve that problem. Alright, so of course I will tell you what not to do or what to do. So the thing is that you have vertical or horizontal. You want to split the teeth vertically or you want to decoronate the teeth. It all comes back to this. Everyone has a zone of probable sectioning because you're using straight handpiece. So your straight handpiece will come in either like this, like this, like this, like this. So you will have a zone. When you are new, you stick to mesial because that is the most doable section. That is the best angulation for your instrument. I'm not saying that don't do horizontal because you have not know how to hold the instrument until you can do a section that you want. Because drawing a line on the OPG and then I tell you how you put like this, like this, like this, like this, but you cannot do it, you cannot execute it inside the mouth. Understand? So this is the zone. And your zone will get wider as you get more experience. Then you know how to navigate things inside the mouth. So because of this, you will find that even for horizontal or vertical, I personally do tend to do more vertical section than decoronation. Okay, but yes, I do decoronation also. What happens is that if you have a mesial angulated teeth, I want to use my mic. I want to use my mic because if not, I'll lose my voice at the end of the day. Yeah, I think I will try. Because I had experience, I lost my voice. Okay. Hello. Hi. Okay, all right. So if it is a mesial angulated, I don't have to shout. So if it's a mesial angulated, I realize that what you want to achieve, ideally, the section that you want it also falls into your zone. Understand? What I want to do is doable. Even if you sengit sikit pun, it's still not too bad. Okay, I will come to horizontal later. Which means that due to that zone, that one is my own interpretation. So mesial becomes the most favorable, the kind that you want to take. And when you have horizontal, but the occlusal table is still higher than 7, you can still always do a very favorable split. Okay? Of course, all other features means the BMI, the age, and all that. Okay, I will come to horizontal later. Let me just finish this case. So what happens is that, how do you do a section? Of course, the section always start from bifurcation to the occlusal plate, not the other way around. Not start from top to bottom. This is my officer. He likes to use a round burr first, make one hole, then only put in the fissure burr, and then only he starts to cut. I don't do that, but it is up to you. I always allow them to do whatever they want to do. So they do the gutter, he use a round burr to the assumed bifurcation. Sometimes you don't see the bifurcation. They will say, do the gutter until you see the bifurcation. Sometimes you don't see. So if you don't see, you just follow this groove, Every teeth has this groove. At least I think you will see that groove for the egg. Follow that line down. Hopefully, pray that is the bifurcation. Okay? That's so much bleeding. You can't see, you can't feel also. Then you go down there. We're using fissure burr. It's always like a saw. Because they don't cut at the end. They cut at the side only. So in, out, in, out, in, out, in, out, until you reach as close to the occlusal table as possible. Alright? The tooth structure is hardest on the enamel. So if you don't go as close as possible, but don't cut the 7, sometimes the break won't be good. Because the lingual side, the occlusal side, all the enamel is thick and intact. Then you break and they're all still in one piece. Shit. And the thing just become harder. Okay? So you try to go in, you must at least go in more than half. So today with a bit of experience, you can get to know how deep you need to go. So this is actually the case. It's actually quite difficult and it's very bulbous. Right, then you want to split. I told you already, try to go beyond the mesial distal width, try to go more than half. And during the hands-on, I'll explain again how you want to know how deep. And then of course for tooth splitting, you don't have to wait. You just put the smallest instrument along the section that you have already done and turn 90 degrees. If turn 90 degrees still no crack, then you know the instrument you use is too small, isn't it? So your section, try to make it a good straight line, not zigzag, not a very broad one. Use the instrument that is largest but reach the end of your sectioning. Means that if I can put in straight Warwick James and I can put in Couplam 1 at the same time, both instruments can reach the end of my section. Which one would I use? I would use Couplam 1. But most of the time it's just straight Warwick James only. Because that is just nice for the routine fissure burr. Don't use the one that is loose. Then you turn also, it's not going to break your teeth. Okay? And caries teeth also sometimes a bit hard because the dentine is already so affected that it becomes so soft. When you turn, it doesn't break. So that one is another issue. Alright, so the bad split is what I say is that only these two buccal cups fracture. Aiyo, the rest is intact. Then you're having a little bit of difficulty for the remaining one. Okay, now one thing I will tell you, give space and you do not force. If you force, you just come out with 1,000 million pieces. And and that is not the kind of MOS you want to do. It'll take a long time. So you want to know that if it failed, what is it? Is it I did not give enough space around the teeth? Because for the teeth to split, they need space. They need space for the fracture line to propagate down. Understand? And once you have a split already, now everything you reassess. Where is the remaining tooth structure? Do I need to redo my gutter? Because now the remaining tooth structure is below my bone crest, isn't it? But you don't redo the gutter because you want to section the remaining tooth structure. It won't happen because you didn't give space for the root, the mesial and distal root to split. Understand? So when the teeth fractured, you have to reassess the condition. What do I need? Do I need to give the remaining tooth structure more space? If that is the answer, then you have to do the gutter again at different place. First time you do atas, you take out the crown already, now you're struggling with the root. You might have to do gutter again around the root. Right. So sometimes you can have retained root, okay? You have to inform the patient, I told you already. Okay, so let me finish this. So we take out the crown, and then you have distal and mesial root, but there's no rules that you must take out distal root first, then only you can take out the mesial root. As long as any of the root is loose, you take that out, and the remaining, you take them out, okay? Now, sometimes you can't. You can learn to use curve origin. Must identify whether it is insufficient mesial buccal guttering, so you do not have a good point of elevation. That is one of the beginner's mistake. Is it because distal bone was too thick on the lingual bone? Is it because the distal cup 7, but you don't trim the 7, or is it because unfavorable root anatomy? So you troubleshoot. During the surgery, you need to know what is it, then you eliminate that. Alright, so horizontal, textbook will tell you, wow, do the gutter, do like that, straight like this and do straight like that. And sometimes I can't. Even though I want to do that, you end up like this, or you end up like that. So one thing I want to tell you is that if you do decoronation, please leave a little bit of tooth structure at the floor, because if you go through, you may injure the nerve bundle. Always leave a little bit. Okay, so you have horizontal. All these are horizontal already. Ideally, you want this or this. Why? Because you want what is at the bottom narrower than what is the space you created on top. So once you decoronate, this whole segment can come out. But to do this with your straight handpiece in the mouth, I can't. So you end up will be this or this. Alright? So what do you do? So let's say I do this. I take out, the crown came out. Luckily, it came out. Okay, but the roots are intact and in one piece. So I will try to split the roots. This is one of the ways. Try to split the roots. Once you split the roots, you want to take out either one of the roots. If you cannot elevate the distal roots, most likely because you're having this, because you need to upright the distal root. So the root anatomy is like that in the sense that it wants to come like this. But you want to change the pathway, means you have to give more space. So this is one way to troubleshoot it. Another way, you did that, but the crown refused to come out. It refused to come out because maybe your section is slanted slightly. So now, fracture already, but it's inside and it's stuck. You cannot come out. You can actually section it again. There's no rules that you must do only one time. You can do multiple times. Or you can even go the other way. As long as you have engaged a little bit, put your instrument, break, the crown becomes 2 small pieces, then you take them out one by one. Right, another example. You do this, you do the section already, okay? You try to take out the distal crown and the distal root out, giving a lot of clearance at the distal side. I always emphasize this because this is safe here. A lot of people dare not do the bone guttering distal side, but there's no nerve there, there's nothing there. Take out. If the bone blocks you, just take the bone out. Alright? There's nothing vital there. So then, if you could take the distal crown and segment out, what's left is a big crown, locked distal to the 7, and the mesial root, isn't it? If you can, upright this, even if it's just slightly. Take it up a little bit. So now it came out and it usually will get stuck. It usually gets stuck, but I'm happy. I'm happy because it gets stuck. Why? Because the next thing I want to do is to insert my fissure burr and go up. Do not put your fissure and go down, because the toe set tooth will drop down again. Because I've seen them, now I want to decoronate. Then they start from top one. I said, no, you start from bottom. And once you can elevate it a little bit, you get this space, isn't it? And you know that you're further away from the whatever at the floor of your socket. Understand? Try to go from below and go up, and now usually you can take the root out, the crown out, and the root will come out. Doesn't matter if it gets stuck. If it's the firmer it gets lodged in, the better, because when I section it doesn't move. Then I section lah. Understand? Okay, very good. Okay, let's try again. So this case, very minimally cut, only the distal cups came out. Ayo. Both roots intact, crown intact, everything intact. Huh? So how do you troubleshoot? Again, you deepen that section, because you did not reach the pulpal floor and beyond. This is different than RCT. RCT never go beyond the pulpal floor. MOS always go through the pulpal floor. And then you do the distal bone removal. Again, you try to upright it if you can, and then you do it. So you must know what was the problem. If only this come out, root is intact, you inspect. Root is intact, you didn't go beyond the bifurcation, then redo that step. Because no way you're going to take the root out, you still need to execute what you want to do. So if it doesn't bulge, let's say you could not deliver this step. From here, I want to upright, I cannot at all. You have to know why you could not. Is it because it is so tight? Is it because your mesial buccal bone has not been reduced enough, so your instrument could not engage and up and tilt the teeth up a bit? Most of the time, horizontal case, you need to do that buccal bone, you really need to bring them down. You don't bring them down, light doesn't go in, instrument doesn't go in, you cannot do. It's different than mesial angulator, right? Bring the buccal bone down. All right, now if you really can't take it out, what do? You can still go from top and section it lah. Just don't go beyond. That one is a bit difficult to gauge, because you do and then you look, is it bone, is it still teeth? You do and then you look, suction, then you decide lah when to stop. This one is a bit difficult to teach lah, I would say. But try not to go through and through. Try not to go through and through. Alright, then this is the one that I said I will show you. When one root is out, how do you take out the other root using curve Warwick James? Okay, now we talk about elevation already, the section where we will put an end to it. Now, when you take it out, sometimes they get stuck with a dental follicle or a very thick tissue around it. Usually, do not just forcefully tear it out. If it has a very thick follicle and you forcefully tear it out, sometimes you might even tear the lingual mucosa. So try not to forcefully tear it out. Again, same concept. You elevate, it is stuck already. You are holding the langan back, pass the langan back to someone else. Hold that teeth. If you can, lockable instrument, artery, needle holder, at least something you can lock. Because once you hold the teeth already, you want to pass to your left hand. If you use a tissue forceps, tak boleh kunci kan? You pass to the left hand, longgar already. And then this is your non-dominant hand. If you can, hold that teeth or hold that tissue. Use your artery or something, hold that tissue. Okay, hold with your dominant hand, which is in my case right hand, pass to the left hand, then your right hand take a periosteal elevator and try to detach slowly. Understand? If you do it atraumatically, at least you don't tear the whole lingual mucosa. Faham? Slowly. So this is what I mean. Langan back, someone else hold. My artery is holding that thick follicle. This is my left hand, this is my right hand. Understand? Can I know who is a left-handed here? Everyone is right-handed. Everyone. Oh, lama, Dr. Jin. I have an assistant. He's left-handed. He will always help the participant who is left-handed. But he can do surgery on the right hand also. Alright, so that's it. This is also the same concept. Same person, right hand, left hand coordination. Alright, once you do this, always do a socket examination. What do you want to see? Inspection. Number one, if you see a cut like that by your fissure, you know that you went too much. Okay? If you think that you went too much, the next thing, usually out of curiosity, I will put a probe 9 or a tweezer. I will go into that groove and I just push lingually and see whether there's still bone or I already went through all the way. Understand? If I already went through all the way and I didn't know what just now how deep my fissure burr went, then you like inside the heart, okay lah, watch out for lingual nerve injury, because lingual nerve is there in the soft tissue plate. The best is that you take all the teeth out and you don't see any grooves lah. That is the best. Means you did not over section. But if you see the groove and you just see, and then you put the instrument along the groove and you went lingually, but there's still bone, then you are safe. Your lingual nerve is definitely not injured because you did not went beyond the bony casing. Lingual nerve is in the soft tissue. Right. Then you want to see if there's lingual bone fracture. You want to know if there's any excessive bleeding. You want to know the status of the 7 and the mobility also. Right. So always I will do that and tell the patient, caries or not, need fluoride gel or need cavity. And then sometimes at this point, I will let the patient bite the gauze, I will rest, I'll take out the bite block already. Usually I don't keep the bite block until I suture. I will take it out, sometimes I massage a little bit, let the patient rest a bit, and then I will check the teeth that comes out, whether it is entirely out, have a look, and patient can have a rest, because usually my suturing I'm done without the bite block. Patient open themselves only, and my assistant can see better also, without the bite block blocking them. So then you just check whether you went through and through, or you are just there lah. So this is what I mean, you try to section beyond 50% of this tooth structure. If this is the tooth structure, you want to go more than that lah. If you're halfway just like that, usually it's a bit too little, you have a bad split. And if you look at the fissure burr, most of the time, the whole cutting flutes of your fissure burr are all in the teeth. Usually they won't be outside. If you are outside, usually means your sectioning is not deep enough. Of course, every brand of burr that you purchase is different, but most of the time, the whole flutes will be inside. All right? Okay. So of course, lingual nerve injury. Lingual nerve injury, they are just the general sensation and also the special sensation of the tongue, which means that anatomically, it's the chorda tympani of the facial nerve that joins and travels together with lingual nerve and goes to the tongue. It means that it's strictly speaking, it's not trigeminal, but it's facial nerve. It's not cranial nerve number 3. It's actually cranial nerve number 7. But you don't know also, never mind, it's okay. Just remember what I say. Okay, then closure. Okay, I will always curate, this part. I always curate to have a visualization that good. You need an instrument and you behind 7. Surprisingly, if you don't do this step, a lot of time there you have fragments, you have calculus, you have a lot of granulation thick tissue, a lot. And if you do that step nicely, they usually will come back healing less complete, rather than you leave some fragment, leave some calculus there because you never do it. Because in order for you to inspect such a clean teeth and root or interradicular bone there, you need to remove the granulation tissue there. All right. So, okay, then you can do your bone filing. Bone filing is only done at the area where your flap rests. So you have done gutter. So if I cross-section your socket, this is your socket, okay? You will have a gutter, then you have your buccal bone, isn't it? This is lingual side, this is lingual side, this is buccal side, okay? So you just want to file this area, You don't need to file all the inside one, because your flap will rest. That is the one that I want the bone to be smooth, that's all. Inside will be jagged and all that is okay. Understand, Okay, very good. Then you file the bone a little bit. Then I will always take my langham bag out and change to a tissue forceps. Means that I won't irrigate with my langham bag there. Why? Because a lot of debris will stuck underneath my langham bag. If I don't take it out and hold it with a tissue forceps and flush, sometimes by the time I flush, I want to close already. That's when I take out my langham bag and change to cheek retractor. Still have debris there and still have fragments there. And I learned that the hard way. Later I'll tell you why. So I always change to that, then I will irrigate. Then I will plug in my hemostatic agent, gelatin, spongiostat, Surgicel, whatever that you use. And I don't just simply put, I will put specifically into the socket. If it's 2 roots, then 2 pieces. If it's 1 root, then 1 piece. Some will tell me, no lah, I switch it until the last one only, I put because when I suture, it comes out. It makes my suturing difficult. Kan dia suture, then dia terkena and then it comes out. So, but because you don't pluck it at the top, you pluck it at the bottom where it bleeds. So usually I will do that, because if you put in your hemostatic agent before your last stitch, you can't see well already. You don't even know where your hemostatic agent is. You just simply put there only. Most likely they're at the top part. Then you still have maybe some bleeding there. Then you get hematoma and all that, post-op swelling and all that. All right. So make sure no bleeding, all that. Then you place your hemostatic agent. Then you start to close. Yeah. Right. To close, the principle is always flat to base. Not base to flat, means from here to there, not from there to here. Disregard you're doing right side or left side. Some people are so used to suturing only in this direction, so when they do the right side also, they will suture this direction. It's always flap to base because you're advancing the flap to the base. This is principle already, it doesn't change whatever surgery you do. So again, also we always stand at the opposite. I don't teach you sitting on the patient's right and do MOS on the patient's left. I will always teach you standing on that side. So when you suture, you always start with the tip of your triangular flap, and the first suture, you don't take both parts in one go. First suture, only first suture. Why? If you take both bites in one go, you are most likely going to end up this direction and you will leave a gap there. And then foot goes in, then you have dry socket and things like that. But if you do one out already, I will actually purposely angulate it so it points mesiolingually from the 7. Then only I tie. You will have a very good closure behind it. Less risk for foot or clot to come out or foot to go in. So this is what I do. And then when I do this bite, all my assistants know, because I can't see. Once I take the first bite, I want to take the second bite, I always ask them, good bite or not? Because I can't see. Unless I will go like that, then I can see where my needle comes out. But my assistant has the best view. So all of them know, when I take that, good bite or not? If your bite is too shallow, you will tear when you tighten the knot. So my assistant will tell me, good bite. Then I find my needle and I take it out and I tie. So this is between you. It's not more than one person, you know. Your assistant needs to know what to do, when to do, what to do, all that. Right, so this is what I do. And the subsequent one, you can take both bites in one go, is okay. But this is the most critical one when you close. And this one will advance the whole flap, and usually your relieving part doesn't require suturing anymore. Because if you don't close it, foot tends to go in or clot tends to come out, you have problem. You have problem like dry socket, things like that, pain. And if you have it tight, clots doesn't get dislodged, you don't have a lot of post-op reactionary bleed, you don't have foot going in, you have less post-op discomfort. Doesn't mean that you want it to heal primarily. No socket will heal primarily. Despite that I get them closed like that nicely, it will come out like that 1 week later. All sockets will come back like that. It's okay. That one is during healing, I will explain to you again. So I always milk the hematoma out, because people ask, how come your surgery no swelling one? Because I always will milk the hematoma out before I close the last suture. So let's say I suture already, I will close the outside, which is here, okay? Maybe I hold like that, and then I will use my hand and I will milk at the vestibule. Then I will close my last. Or you close already, but because when I close it's really tight, you know, so I cannot milk the hematoma out already. So usually the last one, I will close the outside, retract the cheek, and I will milk the hematoma out. Okay, and then I will close. Because I don't want any residue there that will cause bleeding, and hematoma is a very good breeding ground for bacteria. Then hematoma has a chance to become abscess, and then you have a problem. Alright, so I always make the hematoma. What I cannot show is where my other fingers are. I cannot show that. So clinically, I actually have my finger outside here to close it. Right? Okay, so this one, I will tell them what to do. You can take a picture, do not play with stitches, do not suck. And I will always tell them, do not. I will do that every MOS post-op, I will do that. Because sometimes they don't know, they will do that. Do not rinse, okay? Do not brush vigorously. Means that from day 2 onwards, day 1, I don't let them use mouthwash also. Day 2 onwards only, I let them use mouthwash. That one also kemam saja. Tilt the head a bit, let the water soak through it, and that's it. You don't even have to swirl the solution inside the mouth like you're drinking wine. No need. Just let it soak there, and then they can spit it out. All right. So all this, and then ice pack, of course. Did I mention ice pack? No. Yeah, ice pack. Okay. Bite and gauze, 30 minutes, all that lah. All right. And then post-op medication, you can also take a picture. I give antibiotics. These are my choice of antibiotics here. Then you have analgesics. Then you have steroids. Then you have mouthwash. What I want to highlight here, just in case you're still not familiar, your analgesics have NSAIDs, paracetamol, and weak opiates. These are the 3 main groups. You only choose 1 member from each group. You don't choose 2 members in 1 group. Let's say, I give Ponstan and ibuprofen because this surgery very difficult. I think you're going to have a lot of pain because you cause overdose lah. NSAIDs have selective and non-selective COX-2 inhibitors. Selective are those expensive ones like Arcoxia, Celebrex. Then you have the one that is always available because this one is specialist to sign in government. Then you have non-selective. This one MO, DO can prescribe because they are cheaper. You have Ponstan, ibuprofen, Votrient. They are all the same group. If you give this, you don't give mix with that. You give already not enough, you mix with either paracetamol or you mix with either tramadol, with opiates. Of course, you have higher opiates until morphine and all that, but you don't have access to those drugs. Can you give 1 member of each group? Yes, you can, up to that level. But having NSAIDs to cocktail with paracetamol have synergistic effect. You will have 1 + 1 = 3 effect. Don't underestimate adding in paracetamol. Because they'll say, Panadol only, doctor, you give me Panadol only. But they are very effective when you combine it with NSAIDs. Okay, done. The thick one is the step dose that I gave pre-op, and then you decide whether you want to give dexamethasone post-op. I routinely do not give prednisolone. Dexamethasone are more potent. I think prednisolone don't give the effect as good as Dexa, but watch out for diabetes, watch out for gastric, patient with gastric. And if they take the dose after 6 p.m., they get very energetic. They can't sleep very well. You can take one before your wedding. Then that whole day you can do all the thing, energy full like me today. Okay, so 1 week post-op, you always have this, You always have this because none of your extraction socket is going to heal primary wound closure. But when you close, you try to get them together. The only reason is to prevent food infection. But when it heals, they always look like this. Okay? And then my hand will come. My hand always come. When I do OPG, my hand will come. When I do review, my hand will come. What do my hand do? Usually post-op, they sit down, I sit down, I say, how was it? I give open-ended question. If they're not happy with me, let them say. Let them say out and they feel better already. Oh, doctor, balik seksanya, pain here, pain there, I cannot this, I cannot that. Let them ventilate. Okay? And then when they say, okay, not too much, then you're happy lah. If they say they have some difficulty, okay, let them say they have bleeding episode, let them tell you. Then you respond accordingly. And then if they have pain, my hand will come up. Does your pain comes down like this and you still have pain today? Or does your pain comes down and by the 3rd day and 4th day, you feel that your pain comes up a little bit? If their pain pattern is, I still have pain today, but I don't know what is their pattern, isn't it? If their pain pattern is like this, and you still have pain today, I see you, I'm very assured lah, I'm not worried. But if the pain pattern is like this, and then today, or starting yesterday, the pain comes up a bit, most likely it's dry socket. Understand? Understand? So even I inspect already, roughly I know what is the diagnosis, and I will hint my assistant. Okay? So you ask for that, okay? Because with dry socket and all that, they will come 4th day, 3rd day, 4th day, a few days before your review, because I put my review day 7 lah, day 7. Alright, then suture removal depends. I still take it out because I think very difficult when the wound has healed like that and then they were just dangling there and doesn't serve any purposes anymore and just blood accumulation, I take it out. But some patient doesn't want or they're scared of pain, they'll ask you, sakit ah, nak buang benang sakit ah. Then you just put some topical if you want. Alright, and then after I do the removal, I will take a small cotton pad, I will wipe the 7 all around. Because they couldn't brush for quite a while. Make sure they're clean. Then after STO, I will flush. because I can't see what's inside, because all the wound will appear like that, right? So I will flush, I'll tell them it'll be a bit nilu, a bit sensitive. I'll flush and see what comes out. Nothing comes out, I'm happy. Some food comes out, maybe not too good. If you want, you can dress it a little bit. When you dress with Algil, it's not that you want to plug in like amalgam, you know. Sorry, you all don't use amalgam anymore. I'm the generation of amalgam. You don't really pack it, you just do a very loose packing. So this dressing prevents food from going in straight inside. At least they're just on top and they go somewhere else. You buy time for the soft tissue to thicken. So I always tell them, they'll say, oh, doctor, but now there's a hole. You know, they'll tell you, now there's a hole. Then my finger will come again. Yeah, when you heal, your gum will grow like this. Your gum will not grow like this. So it's natural to have a hole, but the gum that grows in with the next 2-3 weeks will thicken, and you will feel the hole become shallower. Once it becomes thickened and the hole is shallower, you will less likely have food infection. At least whatever goes in can come out. Understand? Once you have epithelialization, no more pain, very minimal pain. The problem is that the clot dislodged, epithelialization did not occur. You have a lot of pain because the mouth environment and the socket, which is bone, and all the nerve endings are exposed directly to the oral environment. You have a lot of pain for dry socket. Understand? And that's when the dressing helps. Okay, so this is case number 1. Just one example. This is another patient. He is 1 week. Okay, this is the one with the CBCT I show you. Remember I said, don't raise the flap lah, elevate lah, fracture, I still raise the flap. Then, of course, because there was no bone gutter, you can see the healing is quite good because I did not do a bone gutter, remember? So after STO, this is 1 month, because it's my friend, I say, sit down, let me take picture. Take picture again. 1 month, then 3 months, sit down, let me take picture again. So, nothing much lah, huh? And then you have also another example. This is pre-op, and this is 3 months post-op. This patient have quite a number of foot stuck. So you see this indentation is because if you have foot stuck and you do not remove it fast enough, that foot stuck will occupy the space, so your gum doesn't have that space to regenerate. So sometimes depends on patient. If they tell you and then they biak sampai tengah hari baru dia rinse and all that, then you can get healings like that. Okay, another one. This patient came to me once for MOS, right side. 1 year later, he came back. And why did I take an OPG for the patient 1 year later? Because he wants me to take out the other side lah. I don't purposely subject patient for radiation. So I said, hey, let me take picture 1 year. Again, patient let me take picture. So 1 year, it looks like that. Okay? And these are all typical triangular flap. Right. So summary, you want to have a good surgery, first your LA must be effective. LA tak jalan, semua tak jadi. Isn't it? And then safe surgery. Safe surgery is important. Fast surgery is important, but it only comes after you have safe surgery and with repeated experience and practice. Then your speed will come. You don't expect the first case to be fast, isn't it? Because you have to master so many skill set at different level. Only when you keep repeating, that's when you get faster. And that's why case selection at the beginning is important. Once you select a few cases and you have confidence, then you can continue and challenge something more difficult. Alright? So this will be the most important slide for lecture for today. Any questions? Any questions? Any questions at all? Any part that you want me to stop? Then sometimes the OPG part, one point I forgot to tell you because another finger. Remember I told you that I have nerve and teeth, I will show this. Sometimes I will also show this. You have a teeth there, but I wouldn't know if the root is curved like this or like that. I'm trying to tell the patient, because if I see abnormal root anatomy or abnormally short and the root end look a bit blunted like that, maybe curved, But because OPG we see one way only, so we don't see it curved. Understand? Also, this finger will come out. A lot of hand will come out when I discuss with a patient. Because it's very simple, they will understand, yeah, I look at this, and then the root, if it curves, towards my view, I won't see it. It curves inside, also I won't see it. So I will tell them that, so during the surgery, if I find it's curved, I will try to work myself around it. It may be easy, sometimes it's hard because of these surprises we get during our surgery. Okay, boleh. So this is how I take consent and clinical skill. Understand? Because then we'll go to hands-on. Question? Any question? Yes?
For complication of paresthesia, how, when we should check the paresthesia and what medication we should prescribe?
I have a rigid. It's under the slide of complication, which you will take a picture, but I will answer that now. Because sometimes the clinic practice follow up with the patient the next day, if you're in the private lah. So they will text the patient. Your local anesthesia is not going to last until tomorrow, isn't it? And if the patient is still numb, the next day, something is not right. Two possibilities. One is just because of post-op edema, pressing the nerve, that's why the conductivity is not good. So within the first week, you have numbness, or patient contact you, they have numbness. Within the first week, you give steroid. You want all the swelling to quickly subside or even not set in to begin with. Because the more edema you leave it, it compresses the nerve bundle, then the more injury it likely to become irreversible. Faham tak? You tak mau saraf tu tertekan lama sangat. So within 1 week, I will give steroid. And then after 1 week still have, then you know this is not swelling, because swelling would have subsided. This must be subabrasion or mechanical injury. Then you have to start the neurobion, Fitbion, mecobalamin, the vitamin B, which also I will give you a picture, you will snapshot it, at the dose and all that. Okay? Okay, question, anything else? So hands on. Any questions? Anything you don't understand? Yes, yes.
See, when we remove the molar, then we can see the nerve under there. When we put hemostatic agent, can it infect the nerve or anything?
Because hemostatic agent, if you're talking about Surgicel and all that, they are all resorbable, and you don't pack them like very dense lah. If you do visualize it, which I usually do not find it, I don't bother to see whether I see the nerve, because by the time you see the nerve, you're in problem. Usually you see the nerve means you injured it already. So I'll be very happy, all my MOS, I don't see the nerve. But if you do see something running like that, assistant, do not suck until like always they suck, they will pull all the way to the end of the socket. Don't do that, because you don't even want the tip of your suction to touch the nerve and scratch the myelin sheath. So don't do that, and then you just irrigation and make sure, oh yeah, memang lah, I think this is not good lah. Then you put your hemostatic agent, but don't press against the nerve bundle. Usually you won't see it because there will be bleeding. There will be bleeding, you won't see it. Unless you really flush until it's so clean, then maybe you can see it. Okay? Did I answer your question? Okay. Anything else? Yes?
When will you choose not to STO after 1 week review?
Only when patient don't let me.
Oh, okay.
All my case I do STO. I feel that after STO they feel so much comfortable, especially because I will try to advance them so they feel that tightness a bit. The tightness like they're being pulled slightly. So once I do the STO, they feel much more comfortable. They don't feel so tight, now they can do the oral hygiene care better. So I do it all, unless they refuse to let me do it. Which I will then persuade them, I will put topical for you first. Bagi kebas dulu, and then I do it. Okay? Yes. Question? No question? Question? No question? Anything else? Not easy also, you know, STO. Sometimes you know, not easy. Yes?
If for patient after taking OPG, they want to consider about the treatment plan, usually how long will it take the next OPG? I mean, like some patients.
Oh, you are asking me validity of OPG. The information, I take 6 months lah. I personally, and that's why that 1 year later, I repeat the OPG. I feel things would have changed lah. I think 6 months is a very safe period of time lah, because you're doing surgery again. And then anything exceeds 6 months, I will tell them I would prefer a 6-month validity. But if you have financial constraint, you do not want me to repeat an OPG, I will still can do the surgery with that 1-year-old OPG, but the risk both of us has to bear lah. Me and you, the patient must understand. It's together, it's never alone. Understand, eh? And also your comfortability. If you're not comfortable, then ask patient to take again. Okay, anything else? Very good question. Okay. Right, so for today's hands-on, don't worry, you can approach me, and because I need to keep the thing on schedule. So for the hands-on model, you need to know that our model is fully buried. It's not partially erupted.